which is just to say drop out of care for any reason, including death, and retention. And then the other outcome was viral suppression. For those that remain in care, how many are achieving the goal of treatment, which is to achieve viral suppression. And we use a bit higher cutoff point than the one that is used in routine program. We used the cutoff point for virologic failure of greater than 400. And then after looking at some of these outcomes, to also look at some of the interventions, including interventions that are being implemented as part of routine care, and how has their effect has been in improving outcomes in this age group, and then afterwards look at what we can do to improve some of these outcomes. So the cohort over this period had a total of around 38,000 adolescents and youth between the ages of 10 to 24, and we disaggregated this analysis based on the outcome. So for the attrition outcome, we included all these adolescents over this time period. Then we followed them up until early 2022. And then for the virologic outcome analysis, we excluded those that did not have the outcome measure of interest, including some of which had moved away from the supported facilities in Dar es Salaam before they could have been assessed for viral load. So, but also we limited it to the period that viral load was being offered as part of routine care, which was from 2016 to 2020. So for the first outcome, we had around 38,000, and then for the second outcome, we had around 12,000 adolescents. And then we used Cox regression for the attrition outcome and generalized estimating equations for the viral suppression outcome. And in this case, we used all the viral load results that were available since they enrolled in care between 2016 to 2020. So in terms of what we found, on the attrition stroke retention, what is the picture that is being shown is the Kaplan-Meier curve of retention, looking over the up to 16 years that we followed up this patient. What we can see is attrition is high, 22 per 100 person years, and it's much higher in the first year of treatment. More than close to more than 2 times at 51 per 100 person years within the first year of treatment. Then it goes significantly down to 15 per 100 person years in the second year, 10 in the third year, and continues on below 10%. But again, attrition is high, and it's highest within the first year. And then the groups that were at higher risk of attrition included those that were severely underweight and those that started same-day ART. So unfortunately, the same-day ART aimed at providing treatment early. The adolescents and youth that started treatment on the same day seemed to be more likely to drop out of treatment. And again, attrition was lower among younger adolescents, among pregnant female adolescents and youth, and among adolescents with advanced HIV and those that had started on a dolutegravir-based regimen. And then with regard to the intervention, and we looked at 3 interventions that have been implemented as part of routine care over some of this time period. This included Saturday clinics, which are dedicated adolescent-friendly clinics on Saturday to attend specifically adolescents and youth. We also have clubs, adherence clubs, which are adolescents and youth-driven gatherings about a month, once a month or once every 3 months, to share experience with regard to HIV care, experience with regard to using ART, but also support each other on adhering to treatment. And then we also looked at pairing intervention, which is specifically targeting adolescents which have high viral load, pairing them with adolescents that have suppressed viral loads, and trying to see if we can harness the potential of peer support to support the adolescents with high viral load to achieve viral suppression. So what we found was none of these interventions individually, and these were assessed at facility level. So we looked at facilities that were implementing this intervention versus facilities that did not have this intervention. We also looked at facilities that had either 1, 2 or all 3 interventions versus those that did not have any. And what we found was, looking at them individually, none of the intervention had significant effect on reducing attrition. However, a combination of some of these interventions in facilities that had either pediatric clubs and Saturday clinic, or pediatric clubs, adolescent and youth clubs and pairing, had much better outcomes in terms of lower attrition compared to those that did not have any of these 3 interventions. And then moving on to the second outcome of viral suppression. Again, for this we found that 12% of the adolescents had virologic failure, which is viral load greater than 400 copies, and the virologic failure was higher in younger adolescents, higher in adolescents with advanced HIV, those that were underweight, and those that were on nevirapine regimen. And then it was lower on longer duration in care, lower in non-pregnant female. In this case, same-day ART seemed to be better because virologic failure were lower among those that started ART on the same day of diagnosis, but also lower among those that were using dolutegravir or PI-based regimen. And what you're seeing on the graph during the time point 2 to less than 3 years and 3 to less than 4 years, that was the time point that corresponded to a huge transition in regimen from an NRTI-based regimen to dolutegravir-based regimen, which had largely contributed to improved viral suppression in general among the patient population that MDH is serving, but in particular also among adolescents and youth. And in this case, adolescent interventions, again, none of them individually had significant effect, but then in combination, especially in facilities that had all 3 interventions, had a tendency towards improved outcomes. However, this was not statistically significant, which led us to believe that there is need for these interventions to be optimized for us to be able to see the positive effect of these interventions. So some of the next steps of this work is to unpack these interventions and try and understand the mechanisms that contributed to them working where they work or not working where they're not working. And we've heard earlier this morning about understanding mechanisms of the different interventions in implementation research, but also building on some of these interventions and to optimize them based on what we find from unpacking these interventions. And then also looking at some other interventions that may be working elsewhere that can be integrated, that can be co-implemented along with these interventions to see if we can further improve these outcomes. And I believe that's my last slide. Thank you for listening.
Very much. Good luck. Can I now request Joan Gemalira? She's from Muhimbili National Hospital, and she'll be talking about viral suppression and drug resistance among adolescents. So a change in the title. Karibu.
Thank you, Professor Bakari, and good afternoon, everyone. I'm requested to take a shorter time, less than 10 minutes. I'll try my best. And I will share with you the findings regarding viral suppression, of course, has been mentioned earlier, but we'll look into their drug resistance patterns and a few of their correlates in the same population we are discussing today. But now we are looking into the picture that since we have rolled out dolutegravir, a drug that is believed to bring kind of a game changer in terms of viral suppression. So much has been said by the previous speakers introducing what is really going on, but of importance here to mention is about drug resistance, which we are all aware that antimicrobial resistance all over the world is a global challenge, and HIV is not really an exception. So we need to look into that in the sense that when we look into the efforts that are being made by global communities or different institutions towards the reach of the UNAIDS target. And here we're talking about ending HIV/AIDS by the year 2030. So drug resistance seems to be really a barrier. And through surveillance or studies, we get quite important information of what works in terms of treatment, which is termed as drug susceptibility scores. So this informs really us clinicians on what really is working, and we are thinking that we need to implement effective ART. Different reasons have been mentioned already about the higher rates of virological failure, so I'll skip that. So basically, I'm presenting the evidence that we did a cross-sectional analysis from the first national drug resistance surveillance that was looking into acquired drug resistance, which was done in the year 2020. So the age group we included in this analysis is the young adolescents between 10 but as much as young adults, so 10 to 24 years of age. And the study sites here were about 36 facilities, and these were sampled to at least represent 90% of the care and treatment clinics in the country for the surveillance purpose, using a two-stage cluster design, whereby they first select the clusters, and from each cluster, now we randomly select the participants. So for the period of 3 months, between July and October, and if you all recall, we had COVID by that time, but it was a success surveillance. And samples that were collected from the participants were dried blood spot samples, which had to be shipped to Canada for genotyping. And the analysis was done using the usual Stanford database algorithm. So the figure on my right, and I think on your left side, displays where we included our study population. So we had around 2,030 participants overall. And as you all know, it's children and adults, but yeah, in between we have adolescents. So we excluded in this analysis children who were aged 18 months, but younger than 10 years, and also adults who were aged 25 years. So we are left with around 578 adolescent and young adults. These had viral load results, and as we are aware that we are using a threshold of 1,000 to cut a line between suppressed and unsuppressed. So 8 samples had invalid viral results from the laboratory, so we excluded them in this analysis, and then we remained with 570 samples. So among those, 506 had suppressed, as I mentioned earlier, the threshold of 1,000, but 64 participants did not suppress, and these were subjected to the genotyping. So here in this table is showing the participants' characteristics. We'll see that we had predominance of adolescents who are 10 to 19 years, around 93%, and females, as we always hear. And the ART that were used, as I mentioned earlier, there was introduction or transition from using the previous efavirenz-based from the class NNRTI. We transitioned to dolutegravir, an integrase inhibitor. So majority of them, around 84%, we are using INSTI-based regimen, and only 11.2% did not suppress at that time. So among those who had high viremia upon one measurement, as we defined virological failure using 2 measurements, but for the sake of this surveillance, we had only taken 1 viral load measurement to define high viremia and not virological failure. So we had, as I mentioned, 72% had at least 1 class drug resistance mutation. So I'll explain more in these figures here. So in the first figure on my right side, you see that there's predominance of still people who were still on using NNRTIs had around 68% resistance, and we all recall that this was why we transitioned to dolutegravir. And NNRTIs was the following class that is had around 44%, but the rest were really less than 10%. If we try to look at the proportions, if we combine, as you all know that we normally use either combined, not really dual, but triple therapy, but if we try to look at combined, using the NNRTIs and NNRTI, we found 42% had at least a drug-resistant mutation. If we combine NNRTI and PIs, which we mostly use in our second line, around 6.5%, NNRTIs and INSTI, which is basically dolutegravir here, is around 6.5%. So here, just bear with the molecular mutations, but I'll simply tell you what it tells. Yeah, so the NNRTIs, we picked the prevalence of the mutation that is mentioned there as K103N, but we'll discuss in the next slides. And the NNRTIs, we see the predominant M184V, also around 43%. And of note, within this class, the NNRTIs, there's a mutation that we were expecting to find it because this K65R selects for the tenofovir that have been broadly used in our first line. And PIs had less mutations, as you see, but of note, you see that they were emerging integrase inhibitors mutations. So this was just shortly after the rollout of the transition of dolutegravir, but we see we have some major INSTI mutations. When you look at the correlates of the factors, only that the initial viral load status, meaning that if a client starts ART, we know they're going to test at 6 months after ART initiation. So we term this as the first viral load status, which was more than 1,000, had really a significant association with development of acquired drug resistance. And the rest of the factors were not, but of just interest that the males also had a higher proportion, though when we look into the statistical test, it was not significant. So what does all this tell us? That viral suppression has been impressive, at least with the transition, as mentioned by the previous speaker, that dolutegravir really improved the viral suppression into this age group. And when we looked at the baseline characteristics, we saw more than 70% were already on DTG based. But the viral suppression of 88% is not really a target, and we are moving toward the 95 target by the year 2025. So the previous speaker has already discussed a lot about the existing youth-friendly services. We need to tailor them or address them really in terms of the clinical outcomes, the viral suppression, which is the desired or the major outcome that we want to achieve. When we look at the patterns of resistance, it tells us the following information, that the mutations that we see are really reflecting that these patients or these clients were prolonged on failing regimens in the classes of NNRTIs and NNRTI. But of course, if they were diagnosed since childhood, they were supposed to get the treatment, so there was no like running away from that. But if we see also increasing the backbone that we are using until now in terms of ART regimen, the NNRTI is the backbone. We mentioned the tenofovir, we mentioned the other NNRTIs like zidovudine, and we see that if those are increasing also, should it pose us to think also there's an increase of INSTI monotherapy, that we are giving 3 drugs, but actually only 1 is working. And I'm aware that there are several studies ongoing, the clinical trials to look into this. And the presence of the thymidine analog mutations, termed as TAMs, are also giving us a wake-up call that these patients were really, they stayed longer on a failing regimen without being detected. So are we doing much of the implementation of our policies, our guidelines? That's the question that we need to pose and look into that. And much as we are also, our guidelines tells us to use zidovudine in the second line treatment, and we see zidovudine is one of the drugs that be selected by the terms that we mentioned earlier, then we are in trouble. There will be no future options for the next second line or even third line treatment. But also of note that with the prolonged mutations that we have mentioned earlier on, with these NRTI groups, is also prone to cross-resistance. You might find only one drug has the mutations, but with prolonged exposure, the entire class now becomes not working. Then we are left with no options, and this can have negative impact on what we are practicing now. Then the emerging INSTI mutation that I mentioned earlier on can tell us that maybe we needed to have baseline detection of the mutations, or did we have prior minor mutations that were not detected, and with the use of an effective drug, dolutegravir, now they have been amplified and we are seeing them now. But then in the near future, we're going to have failing regimen. PIs have maintained their low resistance, so it's really not really a big concern. But then a significant other factor that I mentioned is that we are not really defining biological failure using one measurement, and we might need to rethink again that if the initial one, the first viral load at 6 months, is showing a strong association with development of drug resistance, then we really need to emphasize either to revisit our timing of viral load testing, much as we are using the dolutegravir, a much faster drug that can cause viral suppression, at 8 to 12 weeks, and we are doing at 6 months. So this is also a call that needs to review. But also we need to underscore the early detection of high viremia, so that the earlier the better we can prevent earlier on rather than exposing to a prolonged failing regimen. So in conclusion, this analysis shows that more than 1 in 10 adolescent or youth had high viremia, and we had seen among those with high viremia, there were few in sample, but among those with high viremia had clinical relevant mutations that really are calling to review how we are going to prevent development of acquired drug resistance testing. And so based on the finding that the first viral load test was really a significant factor for developing drug resistance, we recommend to revisit and either perform genotypic testing at that juncture where it is detected, or during switch of ARVs. This is the time when we use viral load results to switch from one line to the second, or sometimes we recycle the NRTIs. NRTIs are really still the backbone of any regimen, be it first, second, or third. And also, as we have already rolled out dolutegravir in children, it's ongoing in the country, but in the young adolescents, we need periodic assessment of viral suppression in the context of using TLD. And then also evaluate the differentiated service models that we are using in adolescents, and are they really doing us any good, or do we need to do or stretch ourselves much better? So that's all, and I would like to acknowledge the Global Fund that provided funding for this surveillance, the MUHAS team, my supervisors, my mentors, Professor Bruno, Professor Tumaini Nagu, and Said Aboud. His mentorship, Professor Wafai, and Christopher Sudfeld, Professor Mugusi as well, and also my hospital for giving me time to make this analysis. Thank you very much.
Wonderful. Thank you very much, Joan. Our last presenter is Gertrude. She's from Ifakara Health Institute, so she'll give us an experience of HIV in adolescents in a rural Tanzanian setting. Karibu.
Thank you very much, Prof. Bakari. Good afternoon to all of you. I'll try as much as I can to do it very quickly. And as introduced, my name is Dr. Gertrude. I come from Ifakara Health Institute, but currently based at MUHAS, and I acknowledge the presence of my teachers here, including Professor Karim. I'll be presenting about HIV and treatment outcomes among adolescents in rural Tanzanian cohort. How does this work? Yes. So I'll not dwell much in the introduction. So through this slide, I'll only say we are all aware that Sub-Saharan Africa harbors more than 80% of people living with HIV, and that has been talked about before. And across the HIV care cascade, from diagnosis to initiating ART, retaining people living with HIV in care, all these also stand as loophole for these individuals to disengage from care and re-engaging later on in care. And during this time when they're outside care, they continue driving new infections in the communities. And as we think of the 95 target, and even though we know numbers are showing that new infections are declining, we need to think of these individuals. And so I'm presenting today data that's from the Kiulako cohort. Kiulako stands from Kilombero and Olanga antiretroviral cohort. It's based at the Chronic Disease Clinic of Ifakara at the St. Francis Hospital. It is in southwestern Tanzania. And the clinic was established in 2004, and the cohort itself was established in 2005. And this is around the period where majority of the CTC clinics in Tanzania were also being initiated. And it's enrolling consenting individuals living with HIV, and all ethical procedures are always observed. The cohort performs a lot of research in various research areas such as HIV, including the virological outcomes that I'm presenting today, HIV affected and infected families and comorbidities, but also TB, and also in the areas of non-communicable disease. A little bit of a nutshell about the cohort. Since it is its initiation, it has ever enrolled over 12,000 individuals. Loss to follow-up is a problem, and I think this is a common problem across a lot of HIV care clinics. We have lost follow-up of around 5,000, and active follow-up of around 4,000 to 5,000 individuals. Enrollment, annual enrollment has been steady around 400 to 500, excluding the peak in the beginning of the HIV care in Tanzania, where a majority of people were being diagnosed, and also a little bit of a downfall during the COVID years. These are a little bit of milestones at the CDCI since it was initiated. The important one is in 2012, where the electronic medical record and the database was initiated to keep all the data of the consenting individuals enrolled in care. The rest is really different projects and units that are being introduced at the clinic as years go by. Coming back to our group of interest today, that's the adolescent. After now you know a little bit about the cohort. It has been said already that adolescents, looking at the decline in new infections, decline in HIV-related mortality, adolescents do not really enjoy the same benefits as it's been stated in other age groups. And that's also include treatment outcomes, as this age group continue to experience poorer HIV treatment outcome. And looking at what has been presented by the first presenter today, when she thought of 66, 99, and 90% down the 95, 95, 95, we should really think of the 34% who are not knowing if they are living with HIV before we continue celebrating the 90% who are suppressed, because we still have people who are driving the infections in the community. So in this analysis, we looked at viral suppression, adherence, and associated factor among adolescents enrolled in the Kiulako cohort after the implementation of routine viral load testing in 2016-2017. And this it was of interest to us because we see in a lot of research setting, many things are being controlled, and this also in turn fosters adherence. So when we assess viral suppression among adolescents or any individuals in a very restrained research setting, it tends to overinflate the treatment outcome. So this analysis was completely for routine viral load samples. And it was cross-sectional, nested within the Kiulako cohort at the CDCI, where we included adolescents who had been on treatment for at least 6 months at the time point of their first viral load assessment, and with a clinical visit recorded. Definitions were in accordance to the national guidelines, where viral load above 1,000 was considered unsuppressed, and adherence was assessed by visual analog scale, safe adherence, and pill count. So we ended up including 260 adolescents who had fit all our inclusion criteria of age and time on ART before testing the viral load. And this is a summary of the characteristics of our participant. And just to say a few points is that 23% of our participants had virological failure of viral load above 1,000. And majority of our participants were aged between 10 to 13 years, were perinatally infected, and had HIV WHO stage 3 and 4. And then we went on and looked at, when we assess adherence, how does it correlate with the viral load outcome? Because we expect adherence to be assessed at every visit, but as Dr. Joan stated, viral load starts to be assessed only 6 months after initiated of ART, and then annually if you're suppressed after that. So for the assessment of self-report, the self-report of adherence, those looking at the unsuppressed viral load, 42% reported that they missed at least one dose over the past 4 weeks, whereas only 20 in the unsuppressed group reported the same. And the percent agreement between self-report adherence and virological outcome was 76%. But then looking at pillbox and visual analog scale, the percent of agreement between adherence assessment and viral load outcome were rather lower than self-report adherence. And this tells us, when we ask these adolescent questions, or when we try to assess the adherence, will that really translate with what goes on with HIV replication within their system? And then we looked at factors that were associated with viral suppression, and with borderline significance, we saw a tendency that being male was associated with viral suppression, but of not a surprise, higher CD4 count was associated with higher likelihood of viral suppression, and also safe report of never missed ART in the past 4 weeks, and having not disclosed HIV status, which points us to think around stigma to people living with HIV. So lessons that we learned from this analysis was that viral suppression among adolescents, even in the rural setting, is still below the UNED's viral suppression goals. And this calls for age-appropriate interventions to improve viral suppression. And we should think again as we assess adherence at every visit, what are the appropriate methods to assess, and probably we should also listen to the adolescents themselves on how best or what best can reflect their adherence to ART once we assess it when they come to clinic. And probably it's calling for using at least more than one method to assess for adherence. So I thought I should also share one slide which is dear to my heart. And this is about improving HIV testing among adolescents. And when we think about how adolescents get access to tests, get enrolled to care, so that we start analyzing all these down the cascade of care, they need to be tested. And the age of consent for HIV testing in our country is still it's around 15%, but majority still are not aware of that. The adolescents themselves, the care providers do not implement that. But looking at the whole of Sub-Saharan Africa, we see now majority of countries have lower age of consent of 12 to 14 as compared to earlier years as 2013. And I think this would point to findings that were reported by one of the previous presenter who was reporting HIV testing in Eswatini, it was, against Tanzania, where there was only 43%. And I'm aware that in Eswatini, the age of consent is down to 12 years. So we should think about all these things as we think of our adolescents. And that brings me to the end. Asante sana.
Okay.
All right, so the panel is now complete. We're going to slightly rearrange.
Thank you very much, Gertrude, for that wonderful presentation. I think I would like to take this opportunity, first of all, to sincerely thank the 6 presenters here. And I thank you for 2 issues. The first one, I personally requested you to prepare these presentations, and you graciously agreed. So thank you very much, and I do that on my own behalf, but on behalf of the HIS project and the AAVP. But secondly, I really want to thank you for excellent presentations. I think all of you have really opened our eyes when it comes to the problem of HIV in adolescents in Tanzania. And to me, certainly, we have a serious problem before us. 2030 is not very far, but the problems are really big. So I don't know, where did we go wrong? Are the strategies that we have adopted not working? Is Rahma right that whatever we have been doing, we have not actually included the beneficiaries themselves, right from the planning stage to the end stage of what we wanted to do? And therefore, I would like to break the ice by asking Evelyn, with all this that has been presented today, and I know the permanent secretary is also here, whether the ministry now will be in a position to rethink the strategies that this country is deploying to address HIV in adolescents. I think we have had very good evidence here. We are not at all doing well when it comes to HIV in adolescents. So this panel discussion now is open for people to comment. We do not have a lot of time, but I think this is a very, very important issue that we need to discuss. But in view of the time constraints, maybe just a few comments from the audience. But also I would like to let you know that in the HIS grant, in the HIV Implementation Science grant, we are also planning to have a session where we are going to deliberate specifically on HIV in adolescents in this country. So we will have another opportunity as well. But may I welcome the audience to contribute to this excellent work. Yes, I can see 2 hands there. So atakayesimama ndo wa kwanza. Atakayesimama kwanza ndo wa kwanza. Good. Karibu. Introduce yourself, go to the point, and target the presenter that you want to respond.
I'm Elizabeth. I'm with MDH. With the emphasis on mental health over the recent years, we have heard from the panelists how all these interventions have been adopted, and yet we're still struggling. How we looked at the prospect of including pediatric psychologists to try and bridge the gap between the current information that we have, evidence that we have that this can work, and actually relaying that information to the beneficiaries, as Rahma emphasized. But we are also looking at another group, that is the parents who are caregivers or other caregivers who are working with adolescents with HIV. How are we trying to help them to understand the disease? And psychology is a huge part that needs to be addressed.
Okay, and your question is directed to?
All the panels, whoever is ready.
No, pick one.
Evelyn, would you help us?
Exactly, Evelyn, yes.
Can I take another?
Yes, Redempta.
Thank you very much to all the presenters. As Professor Bakari was very excited to the place of the. My question goes to hospital evidence and some of the researchers here. So, one of the key barriers that really prevent us from reaching the epidemic control we are talking about is structural barriers related mainly to the political environment. We have very good guidelines, we develop them together, but we know that if we don't provide equal or even more access to the vulnerable population, the key population, including female sex workers, MSM, and so forth, we will not end HIV epidemic because they are part and parcel of the community. So for us as researchers here, how can we actually use research to understand first, why is it a problem to accept for those who make decisions? I think it's time not to just complain and blame, but really to do a research to understand why is it, and if there is any preference of conducting, the research should also try to understand what are the best ways of providing access to these populations, so subpopulations, so that we really make sure we control the epidemic. Thank you.
Thank you, Redemptor. And Professor Fauzi?
Great. Really excellent presentations, all of them. And there are many questions, I'm sure, in the audience. But one that caught my attention is Dr. Miriam noted that males have higher mortality, if I remember. And Dr. Gertrude, that males are less likely to have viral suppression. So if you could comment on why that is the case and what can be done.
Okay. There was a hand there. Sijui umeinua mkono wa kushoto. Sikuoni vizuri. Haya, huo wa kulia sasa hivi. Inuka basi. Yeah.
Okay, thank you very much. Especially, my question goes to Gertrude. I think we talk about the viral suppression and adherence, though we try to take it as the measure of the adherence to viral suppression. So I find it to be like a proxy, because there are so many ways. Somebody may be adhering to drugs, but the drugs are not working. So part of the study, I was just thinking, is there a possibility of looking beyond that, beyond somebody having the viral suppressed, but they might be having other factors which are attributing to they might have a good adherence, but they are poor viral suppression. So.
Okay, can I ask the panelists should respond to whatever has been asked. Maybe some of the prospective questions would be answered. So can I start with Evelyn?
Okay. Thank you, Professor, and thank you all who asked the question. I expected most of the question, especially the one saying, why don't we involve the pediatrician and the other psychologist on the issue of tackling the challenge of HIV to age-Y and the other adolescent groups. Starting by, I can say the government has worked a lot on the issue. If you remember, before this data that I've explored today, the age-Y was, those who knows their status was below that. So after lowering the age of consent, at least now we have improved. Apart from that, also the government currently now, the Minister of Health, has developed the accelerated plan for case identification to adolescents and youth and children. This one will help. I remember even 2019, we had the same challenges on the first 90. At that time, we were working for first 90. But after having the accelerated plan, it helped a lot until, I think most of us will remember how far we went to the first 90. So with this forum, I also like to inform you there are efforts that the government is working on it, and the comment of involving other stakeholders, including the pediatrician, is well taken. Although we have this TWG, Technical Working Group, where we involve all the stakeholders, including pediatrician, psychiatrist, and so far. So the comment has been taken, and I think for the case of this meeting, maybe this symposium, it's also the area for research. Maybe I can encourage we scientists to take this gap for other research or other study, so that maybe we can get more causes of these challenges for the AGY and the other children. It's the same to the children, to adolescents. Maybe we can take it as an area of research. Coming to another question, someone asked, Dr. Florence, I think, asked about the structural barrier that, Dr. Mbatia, okay, sorry, asked about the structural barriers, that it's time to remove these structural barriers that interferes with the health service for the key and vulnerable population. I can declare interest with the coordinator of key and vulnerable population. We know we worked a lot. The government accepted that approach of public health. We do work, we have the forum for key and vulnerable population, but we mostly working with the groups that we did the research. We have the data that inform their risk of behavior towards the HIV. Maybe also it's the time to look for other groups of the key and vulnerable population to see their risky behavior related to HIV, yeah, so that we can have a big number of people who knows their status, especially key and vulnerable population. Thank you.
Mariam?
All right, thank you. I was asked by Professor Wafai on why high mortality among males. So there is some data that I didn't project, but in my study when I was looking at baseline characteristics, compared to females, most of the males that were recruited into care were at late stage of the disease. So first is health-seeking behavior, and entry into care is late. Females have more opportunities to get tested compared to males in this country. There's a Well Women Clinic. Sometimes maybe in pregnancy they have an opportunity to test for HIV, which is not similar to males. And looking at the HIV impact survey, up to 80% of males had not tested for HIV. However, they had high sexual behavior risk in that population. This is adolescent male, according to the previous HIV impact survey. So yeah, and another thing is poor engagement in clinic, as just being adolescent men or adolescent boys by the virtue of being an adolescent male. Thanks.
Okay, thank you very much, Dr. Mariam. Gertrude?
Thank you very much. I concur with what Dr. Mariam has said about the first question, the health-seeking behavior. But also when we think of adolescence itself, it's a period of a very complex socio-cognitive behavioral development. And thinking of the gender roles that males do assume once they get into adolescence, they don't tend to open up easily. They don't tend to want to engage in areas that they get, like coming to clinic very often. So we see a lot of neurological failure and loss to follow-up among males as compared to females. And unfortunately, this goes on to adults. Even data that has looked into adults find poorer treatment outcomes among males than female. Also adding on to the multiple opportunities and avenues that females do have to get tested. And thank you for the second question of looking as adherence as a proxy to viral suppression. I agree very much. This is a proxy that can be used every visit, but is it a working proxy? That's the question that we had. And I agree with you that we're supposed to look much further into more ways that we could ascertain if the drug is working or not, because it's not really only adherence, although optimal adherence is one of the very key determinants of whether one is going to be virally suppressed or not, or even proceed to develop further complications such as drug resistance mutations and issues with drug metabolism if they were not adherent at the time they were starting their treatment. So yes, we have other studies going on looking into this. And for the mutation, our findings are similar to Dr. Joan's studies. We have a lot of mutation to the NRTIs, the M184V, K64R for tenofovir, the TAMs, and also the common mutations for the NRTIs. Good luck, it's phased out from treatment now. But we're supposed to get ahead from the problem instead of us waiting to find ourselves with drugs that aren't working, adherence assessment that is not working, and then we're found with no means to really keep our adolescent into working treatments. And we're also looking at the correlation between drug concentration in the hair to viral suppression, but that's not a method that can be quickly adopted into all the clinics in the country. So saying things like, let's use more than one adherence assessment method instead of just one is really something that will not really require a lot of more resources for it to be implemented on top of the single assessment methods that's currently going on. Thank you. We can discuss further later.
So thank you very much, Gertrude. Unfortunately, we don't have time to continue with this discussion. I would propose that, because I know we are going for lunch, you can make it a working lunch. So if you have a burning issue, please approach one of the presenters and you can ask a question. But I will give a special opportunity to Dr. Bundala from the Ministry of Health. I think you want to say something. I know you have been touched.
Yeah, thank you very much, Professor. Professor, our previous CMO, and all the participants here. Just a few to make like clarification, but at least to talk in a policy lens what have been said during this meeting. As it was introduced, that we currently have the new department named the Directorate of Reproductive, Maternal, and Child Health, where I am now the Assistant Director looking the newborn, child, adolescent, GBV, and violence against children. So as you can see, basically we have a number of issues to do in that area. And basically during this learning, this post basically have been promoted just 2 months ago. So there's a lot of to learn and coming up with the focus where we need to go. The only things I wanted to say from the Ministry of Health lens, basically we do appreciate the evidence generation activities like the research. Because as we are talking about the policy, we need to set the policy. We need to formulate the policy, to implement, but to monitor. Basically, we cannot set the policy without evidence. And this is the way you need to get the evidence to make the policy the sound policy. It came one of the comments that how do we make sure these evidences come to be implemented? I think one of it we need all of us to see how we can improve this one is to think how do we make the engagement of these policymakers from the beginning, the way we design our research, the way we analyze, but making sure that in a way they are being involved like a core investigators in our researches, so that at the end, it's not just we just come up with a recommendation asking for them to incorporate or to adapt within the policies while the involvement have been very slow or have not adequate from the beginning. I think this is the homework we need to go with it. And the second is about this implementation, and basically just the same month I was given this post, I even think I remember calling Maria and the other colleagues saying, I think we need to have a stakeholders meeting talking about the issue of the newborn child and adolescent, so that at the end, although we are different groups, but at the end we need to come up as a one nation, a common and sharpened focus toward these areas. And we are thinking towards end February or early March, we have these stakeholders where we can discuss and agree by understanding what is happening, who is doing what, to what extent, what volume is really needed, so that at the end we have one as a common sharpened focus as a country, as a nation, that these are issues we need to focus going forward. That's what I just wanted to transfer. Thank you so much.
All right, congratulations for being appointed to a challenging post. In view of what has been presented today, certainly this will be a very challenging responsibility. But I think I should assure you, as far as the researchers are concerned, as far as universities are concerned, you can count on them. Yeah, the question whether you should always be included as an investigator, that is something else. But at least we'll plead with you. When we give you evidence, make use of the evidence. Okay? Right. So, ladies and gentlemen, if I may, can I kindly request that you give a round of applause to our presenters for very good work. And I thank you very much for being part of this exciting session. I think the obvious take home here is we need more engagement and more discussions on the way we should tackle HIV in adolescents. It remains a thorn in the flesh. Thank you very much, ladies and gentlemen. I now pass over the mic to Taj.
All right, can I take you back for a group photo? If you would all sort of stand and come together with the chief moderator in the middle. And once again, our applause to this fantastic group of professionals, ladies and gentlemen. You've certainly paved the way for very interesting discussions at lunch table. All right, we're good. Safi kabisa. So, can I have some good hands? Namba mikono kidogo tuinue podium yetu. We have probably 2 or 3 important items on the program. The first one highlights of the day and the way forward. We also have a vote of thanks
said, Boston, in terms of having people working together, but within a very short period of time, we have managed to come up with 2 vaccines candidates, which is the Johnson & Johnson, and the other one, which is Moderna vaccine. But also the way we are tackling these problems here in the country, in the partnership between, within the PEFA, between different groups, research institutions, universities, and those who are delivering their services. So that's a very important area which we need actually to treasure and to move forward. But also not forgetting the ARISE, the partnership which is existing among the research group, the research group addressing issues relating to adolescence. But we have also seen some sort of a paradigm shift, particularly in terms of integrating human-centered design in our research activities, not only during the asking consent, but also in the designing of research. So we see a new terminologies which have been used now in terms of research on design and how this designing is actually going to happen. But you also see the work which is going on in terms of thinking on inspiration, ideation, and implementation. These are the new things which are going to take us in a much longer time. And I really have to express my sincere, to my colleague, appreciations to Musa on what they are trying to do in South Africa in terms of health and demographic surveillance, starting a people-centered surveillance, community surveillance system, which is people-centered, but also with a very strong component of active involvement of the young people. I've been involved in setting up other DSSs in Kilombero and Bulanga, and the approach was very different. It was mainly, we are the experts, and we just come to collect the data, and it's important for you. And this approach, which our colleagues in South Africa are using, I think is something which is new, and we need also to learn a lot from that. From the DASH, I see the DASH program, which is very ambitious, and I'm sure it will come up with a very strong questions on having blanket policies. I was going to look at the policies across the region, but listening to the presentation which we had here on some of these things which really push the importance of microepidemiology, and so the big question will be how one can tailor interventions and policy based on specific settings. The other one which is very important for me is the work which my friend, Professor Mohamed Bakari is doing on Harvard implementation science. And this is something which is interesting. First, the implementation science is something which is new, and you have heard about many frameworks which Musa has been explaining. But most important for implementation science is the introduction of postdoc. This is something which is very new in our country. When I was at the Commission for Science and Technology, I've been trying to promote that, but I'm glad that I'm happy to see that has been taken, and we are going to have a pipeline of trainees and implementers who are going to really look at the problems which we are facing now in the field as what we have been hearing in our discussion. But also what is important is what you have started to address, being in the importance of data science in the whole thing. Liatu has presented, it seems that has presented a number of data cohorts. If you look at the cohorts which you have started to follow from 2004 and 5, that is a substantial data which now we are now the need for more data analytic capacity, the use of the current technologies like AI and machine learning. So these are some things which are new, and it's really the time now to see how we can use these new approaches to understand more about some of these activities which we are started to pursue. I think what we have heard in the last session is when I was also sitting in the MDH and APH boards, and I really started to appreciate the challenges which our colleagues are facing. It was easy to show. They normally present to us. Sandro, you normally present us this bar chart of 1995, looking at the coverage, but actually that doesn't give us the information on the challenges which have been discussed here, but I've been impressed by how these problems are being addressed from molecular level up to the community level. I think that's all for today. We need to push these efforts together so that we can make a contribution to our public health. Thank you.
All right, thank you. Asante sana. Appreciative hands taking you back to your seats. We appreciate that very much from the Botnar Foundation. Dr. Hassan Shinda, thank you very much. And now a word of thanks that will be followed by the big photo that I was talking about and that special moment before we go to lunch. And may I please call on Professor Pembe, please? I believe you were right. Coming from the right. Very well. Karibu-san.
Unfortunately, I'm not Professor Pembe. Thank you. But it's such an elevation, and I'm truly honored for that promotion. But Professor Pembe would really love to be here with you. Unfortunately, he was not feeling well yesterday and today, and he wouldn't wish to put you all at risk. We are not yet very safe, so I mean, if you don't feel well, and you stay home or locked away. But guest of honor, Professor Pascal Ugadio, and my brother and friend, who is the Director of Curative Services, now representing the Permanent Secretary, Ministry of Health, Professor Edward Makubi, the CEO of APH, my good sister, Dr. Mary Sando, Prof. Mark Elliott, the Foreign Minister of Harvard, Vice Provost, International Affairs, Harvard University, my mentor, Professor Wafai Fauzi, Professor of Nutrition, EPI, and Global Health, Harvard Teacher and School of Public Health, and who is also the mentor to so many. I'm not allowing you to raise hands, but okay, raise your hands. And so many more that will come behind you. But our professor, Professor Mohamed Bakari from MUHAS, former CEO, my colleague, Professor Mosa Moshebela, DVC Research and Innovation, UKZN, Dr. Sando, my brother, CEO, MDH, government officials present, board of directors and founders of APH, Arise Network members from outside Tanzania, and those who are working closely with APH and Arise, my fellow researchers, faculty, friends, adolescents present, the champion who presented here today, special recognition to that. Members of press, I saw you earlier today, and the host, Taji and Amani, wonderful job. So it really gives me an immense pleasure to stand before you and give you this vote of thanks for everything that happened today, and especially having this wonderful symposium. But on behalf of my Vice Chancellor of the University of Health and Allied Sciences, Professor Andrea Pembe, who would love to be here with you today, but unfortunately, as said earlier, he sent me under the directives to say what he would wish to say. So these are not really my words, but his. But really, as the Vice Chancellor of the co-organizer of this university, which is a co-organizer of this event, and your partner in addressing the local and global health challenges through evidence generation, training of high-quality health workforce in Tanzania, and also providing services. So So at the university, MUHAS has continued to benefit from this and many other collaborations, and we all remain thankful for your continuous support and trust. And with these specific collaborations that we celebrate today, the 30 years of collaborations between Harvard and Tanzania, I can confidently say that MUHAS perhaps is the institution that has benefited the most through this kind of collaboration. But also Tanzania in general has truly benefited for the collaborations, friendship, and support that Harvard has provided over the period of 30 years. And perhaps more, that's what we can count, but perhaps many years before that. But through this support, we've been able to address numerous challenges that we had, remembering since the times of the inception of MDH, but perhaps years before that, and transition of these institutes to still MDH, and then giving rise to APH and many other collaborations that came after that. So we really thank Harvard, and we hope that this collaboration continues. But importantly, we also thank the government. Heavy presence here today, the permanent secretary and the colleagues from the ministry, but also the regional government, the RMOs here, and many other colleagues who are working in councils who have also shown here. So we are really thankful for sharing your time and staying to the end. I also saw the Dr. Gemana from TFNC. So we thank you for your continuous support for research, but also being willing to absorb the findings and research that we also continue to do. So this symposium has also demonstrated the strong collaboration that our country has with the US, and has been also collaboratively conducted by APH as our leader, but also Harvard Teacher School of Public Health, MUHAS, Heidelberg Institute of Global Health in Germany, but also many other partners. And this is now over 5 years, going to the 6 years. We have also seen this kind of a trajectory. It's growing in terms of the quality, in terms of the research that are being disseminated, but also through this, our colleagues have also showcased the very impactful research. And with the government presence here, we know that this is the right platform for such kind of dissemination to happen. But also it is strengthening us, strengthening our collaborations and friendship, and therefore for this we really thank APH for taking lead in this, and we request that you continue to offer us such kind of platform. Now on behalf of the organizers, we have always received unwavering support from the Ministry of Health, as said earlier. But importantly, we wish this strong collaboration not only for our institution, but also for every other institution that's working together in addressing these challenges. It's important to continue with this. Now with the efforts that have been and recommendations provided here today, these are the new platforms and way forwards to keep on the momentum. And therefore, please convey our gratitude to the Honorable Minister, Umi Mwalimu, the PS Permanent Secretary, and the colleagues who are working together with at the ministry. We will not have been successful today without the efforts and networks of friends. And may I recognize and give special thanks and regards to Arise Network for turning up in this event and continuing to be true partners in addressing the global challenges that we have had, or we still are going to have in Tanzania, but also in the region as well as in our continent. But the efforts, such kind of efforts can actually lead us into finding the solutions that can have global impact, not only in our continent or in our various countries, but working together, we can move even further. And therefore, we thank Arise, your leadership, and the members that are forming this wonderful network. To Harvard, These collaborations, as I said earlier, goes back decades, and we have benefited a lot, myself also, and several other colleagues that now are working for the populations in Tanzania and in many other countries. We thank you, and please convey, Professor Elliot, convey our gratitude to colleagues who are making this happening, and we welcome you again in Tanzania, and bring others, please. There's so much to learn and to enjoy in Tanzania. We also thank the US government. I saw Jessica today gave us the wonderful speech. Through the US government and of course through various channels, PEPFAR being the almost sole funding entity for the HIV response, of course with other funders, but also NIH, which is funding a number of initiatives in terms of research. So the government, the US government is funding a significantly big chunk of what we do, and we owe thanks to them. Finally, we will not be able to have this symposium without the wonderful presentations of all the scientists that have been presenting here, and wonderful speech by the adolescents, and colleagues who asked questions, who requested further explanations, and everyone else in the room. We thank you for the presentations. We thank you for sharing with us the science that you've been working on, and therefore kindly continue with that trajectory. We really wish to have more output from Tanzania, from our own data, and therefore at least make an impact globally through what we have gone through. We had a wonderful keynote from Mosa. We thank you for the time that you took to prepare it, but also a wonderful work that you do in South Africa. I know we discussed a lot of innovative ideas, and I stole some from you, so I'll give you reports when we have time to talk about it. But we please convey our regards to UKZN and colleagues, and we hope that we'll still work together through the networks that we have already. To all members of press, I'm not sure if you are here still, but we hope that this message goes through, and we count on you as we have always been doing. Wonderful media colleagues, APH, you're doing wonderful work, and I've seen a lot of tweets already, so this is a wonderful platform of dissemination. We have had these research fundings today, but the challenges that we have noted, they keep on mounting, not because they were not there and we are just discovering, it's because that we have increased our efforts to uncover the problems among adolescents. So the work is just starting, I think, and as Rugajo earlier said that there might be many mountains to climb, we can really reach the destination if we work together. We complement each other, support one another, improve the capacity of our institutions and our young colleagues who are in our various institutions, but also reach to the untapped resources, which is human resource that we have. And together we can finally reach the destination. For everyone that I did not mention by their names, please just note that your presence here, your collaboration, and your effort is duly noted. We have work to do. Let's go back to work. Jamhuri ya Muungano wa Tanzania.
Asante sana, Professor Bruno. We appreciate that very much. And my team is going to do a little rearrangement of the chairs so that we can use the stage well. So Amani and Dr. Yusuf, are we all ready? Let's begin with the surprise. The picture, everybody knows that we have to have the picture. The video outside that's on the loop takes us back a year, and we had fantastic memories. But today, this afternoon, I'd like to call on the CEO to come forward, please. And we're all lined up and ready. Karibu-san.
What a day. It's afternoon now. Hopefully we'll finish soon so we can have lunch, and I hope everyone will stay and have lunch. So I'd like to, Bruno has said it all. Thank you very much for such very inclusive thank you notes and the summary of the day from Dr. Mshinda, but also appreciating each and every speaker for very wonderful presentations. So Taji said it's a surprise, and it truly is a surprise. So for some of us and many of us who have been lucky to be in this consortium, to witness the growth of this collaboration with the very excellent leadership of Harvard University and of our esteemed primary institutions here, MOHAS, and all other institutions in Tanzania. And that collaboration has extended to beyond Tanzania. We felt it is important that we also appreciate founders who conceived the idea, but have also continued to champion this idea to date, who continue to mentor us in this effort. And we hope so many more, just as Bruno has said, will be trained and capacitated so that we who live in these very resource-constrained environments and understand the challenges that we encounter every day, not only in Sub-Saharan Africa, but also in other parts of the world, then we may be able to be capacitated enough to learn why isn't health improving? Professor Bakari has just told us how challenging the current area that we are continuing to tap on adolescents is. And therefore, we thought we should, it's always nice to appreciate when people do well, and we continue to learn. So with my colleagues from the Africa Academy for Public Health, but also in collaboration with all the other institutions that Harvard has been collaborating with, MOHAS, MDH, IHI, and all those that have been mentioned, we thought a small gesture to represent the foundation of this long-standing collaboration, that we could do that this afternoon. So to start with, we will appreciate, thank you Harvard for setting your foot to Tanzania, and we would request our guest of honor to come and help us with this next step, Professor Ogayo. May I call upon Professor Mark Elliott on behalf of Harvard University to come to the stage. Excellent. So to present the symbol of our appreciation to Harvard University in the collaboration, this is not only for Tanzania, but also for RISE. The idea was also discussed with Ayo and others. We thought it would be a nice opportunity to appreciate and to hope for even stronger continued collaboration. And with this, we have a small, So with this, we have a small token of appreciation, and I hope it will find a spot in your office or your house. But it is representing our appreciation to Harvard University. I would like to request Professor Ogayo, standing in for the guest of honor, to present it to you.
All right. Thank you very much. I believe the same sentiments, even greater, will go to the following. You wish to acknowledge each one, then you'll go over. Okay, great.
Yes, and secondly, so Harvard University, but also Muhimbili University of Health and Allied Sciences. I believe that was the first door Harvard knocked when they came to Tanzania, and that has opened quite a lot of other opportunities. And with that, we were hoping to have with us Professor Pembe to represent the Muhas community. And Professor Pembe today is Professor Bruno. Please come forward and receive this on behalf of Professor Pembe and Muhas University as our appreciation from the entire network, as we have done for Harvard University.
There it goes. Dr. Mary, you can step in the space between. There you go. And since you keep coming back here and everybody receiving will remain on stage, then we'll have all of you there. Dr. Mary, you may come back for the next one. All right.
So be patient. Everybody's getting something. Okay. Third is to appreciate the great leadership of particularly our local government. The one that really championed HIV care treatment in the country was Dar es Salaam. And with experiences from Dar es Salaam, that spread over even to other regions. I believe Professor Bakari championed the guidelines and all that. But we also know and we appreciate, and in the midst of us, I would like to just introduce Dr. Ayub Kibao, if you may stand. He's currently the regional AIDS coordinator, but within the MDH program back then, he saw the first HIV care and treatment patient and continues to advance this work now, coordinating for the whole region of Dar es Salaam. Asante sana, Dr. Kibao. So is Dr. Hawa Kawawa here? Karibu, Dr. Hawa. So this is supposed to go to Dr. Deo Mtasiwa. Dr. Deo Mtasiwa has championed HIV care and treatment, being a leader in the region for many years as a regional medical officer, and later on became the chief medical officer, and before he retired, he was the deputy permanent secretary for P.O. Rauch, but also has been very instrumental to the founding of HIV care and treatment and many other health systems improvements in our country. So we want to appreciate him, and we're requesting, and also for gender balance. That's Dr. Kawawa, who has also served and worked in the city in Dar es Salaam for a long time. So he's quite experienced and has contributed a lot to advancing this work, to receive this award on behalf of Dar City, but we're presenting it to Dr. Mtasiwa, who has really primarily led this work for many years. He apologized, unfortunately, he could not be here today, this afternoon. So, okay, I'll tell you, it's the last one for today. Well, the last one goes to, can you guess? Professor Afai Fauzi. Please, so I don't think I can begin to say how much Professor Afai Fauzi has been instrumental and core to all of this. I think if I start, we will not go for lunch. So what I want to say is, and again, this was also highlighted even within the Arise network, we thought it would be nice to truly appreciate you and encourage you that please continue always to push, to encourage that it can be done, it's possible, let's try it again. Very softly, you've been able to advance and encourage us, even at times where we felt, can we really find this opportunity and move forward and pave through? Somehow you have always thought it's possible. We appreciate you with all the thinking and ingenuity towards a foundation of 2 institutions and, of course, the Arise Network here in Tanzania, Management and Development for Health, Africa Academy for Public Health, but also in collaboration with many other founders here that I would also like to appreciate, Professor Kileo, who's seated there, Dr. Mshinda, Mtasiwa, and others who are not here. So So I will not say more, but to say thank you also on behalf of the Arise Network, who also knew about this. 2 or 3 people knew. Asante sana. Big applause to Professor Ofaya.
Resounding applause for the recipients. Of course, they all represent all the fantastic work that we all do. All right, so let's see. I think I could split you, 2 of the recipients to the right, and the guest of honor in the middle, and Dr. Mary in between. Dr. Kawawa, please, would you? All right, let me quickly order. I'd like you to come. Yeah, there you go. Yeah, how does that look? Yeah? Safi sana. Do you want them to step up a bit forward? Just, okay, towards the lamp, towards the light. Okay, just a bit, so that you're centered, a bit more centered. And then tell me if you want them to step forward. Yeah, 1, 2, 3, 4. Yeah, that looks good. Yeah, there we are. So now everyone, please prepare for a photo. Let's bring up the chairs. I think we might need the chairs. It's a big number of people. Number 2, Vileta Viti Sasa. Let's bring up the chairs. In fact, we'll have you probably in the same way, almost seated. Tunarudisha Viti? Oh. Tunarudisha Viti? Yeah, let's do that. All right, let me allow you to disperse. I think we're going to have a different type of an order. Seated order. Let's take our prizes back to our chairs. And these are boxed, and so we'll bring the boxes to you. Tuweke viti kwa mbele, towards the front, yeah. So we're going to do 6 chairs. Yeah. One more, just one more. Which one get Rasmus?
Okay, so just to highlight, with Professor Wafai Fauzi's award, it has both MDH and A PhDs. We couldn't put all the partners, so we put as a representation with Arise, but being a founder of these 2 institutions, which was also well appreciated by MDH, I would like to request the CEO to also come forward, because, yes, Dr. Davidson. Thank you. Can I get back to you?
Do we have one more chair? Is it on the wings, perhaps? Okay, so this is a picture. Just one more chair, and Asante. So there we go. That's just a picture, and we'll then disperse, and I'll call you back in order, so we can take our trophies back to our chairs. All right. Looking at the screen, that looks really good. Can I see smiles all around? Yeah, there you go. Safi kabisa. Asante sana. Nashukuru sana. All right, ladies and gentlemen, I will retire you and call you back. The guest of honor will remain. The CEO will remain. I'm going to ask Professor Mark, please remain, and Professor Ofaye, please come back after you put your... Please join us at the high table. Yeah, we'll occupy the final seat. Okay, I think all the chairs are taken. Now, please take your seats. Yeah, all right. Do you guys get the standing shot? May I now call on the board members and founding members in the room, please. We're honored to welcome you to stand behind these chairs. Karibuni mbele tafadhali. Board members and founding members, please come through. Hassan? Okay. Hassan, tafadhali, doctor? Ah, okay, yeah, finally. Almost missed the action. All right, let's thank our board members and our founding members. Congratulations to all of you. Asante sana, sana, sana. All right, next shot, our adolescent representatives. Vijana wetu, are you all here? Or are you the only one standing? Please come through. They're here. Vijana, karibuni kwanza. Let me begin with you. Special picture with just the three of you. Has the young man left? He's outside. Is there some way to get him back inside? Kijana wetu tunaweza tukamwita nje? Please, karibu. Usiogope. Please. Very quickly, hope he's not too far away. And I'll be calling as well as the presenters, the moderators and presenters thereafter. Let me begin with them. Mwanangu, karibu usubiri kidogo. So let's begin with all the presenters. Please come through as we call on our young champions to come a little bit later. All the presenters and moderators. everyone. All right, looks like a good shot. We got it. Oh, hold on a second. Sir, please join this shot. Don't miss on this shot. All right, thank you for adjusting left. There we go. I think that wraps it up. Amani? All right, thank you very much. Have our adolescents returned, or are they being adolescents? They are playing, eh? Boring meeting. You know, yeah, take some pictures in the beautiful surroundings of the Serena Hotel. Well, yeah, that's what they do. So I'm going to call now on our partners, Dr. David, MDH, Dr. Germana, TFNC, Mr. Saif, and Dr. Ali, Zafa, Karibuni, as I acknowledge you, Professor Huai, UDOM, Dr. Mkombe, Tanga City, Professor Bakari, Professor Bruno, Professor Manji, Muhas, and government officials from the Ministry, Regional Commissioner's Office, Karibuni Sana. This is a special picture with all our partners. Please come through. We'll next be calling all the Arise Dash Nutrient delegates after this shot. If we could continue to adjust left a little bit. Smiles all around. Tuendelee kushirikiana. Let's continue with the fantastic cooperation as partners. Thank you very, very much. Mgeni rasmi, guest of honor and Arise Dash Nutrient delegates, come forward, please. I believe this one is going to be a big one, eh? The organizing team stand by. This was always going to be the big one. So if you're kind of tall, you probably want to give a bit of space out front to the shorter ones, eh? How does that look? There's a bit of a space. Oh, okay, this is a really, really big one. It's a bit messy. Yeah, I think it works. It works. A round of applause to you. So many members, you're holding on together very well. Congratulations. And now from the organizing team, from Howard School of Public Health, MUHAS, AAPH, the organizing team at Heidelberg Institute of Global Health, please come back. Vijana wetu vipi? Mmeshakusanyika? Hujampata? Oh well, it's no problem. We'll call up the two of you, and the presenters, you'll take a picture with us. No problem? So Amani and Dr. Yusuf, please stand by. Ladies and gentlemen, a round of applause to the organizing team. Congratulations. It's been another good one. It's been busy. So vijana karibuni. Young people come through. You will start off first. You can see who are the responsible ones. It's turning out to be like that in this country. The ladies are taking the lead. Makofi kwao. Let's put our hands together to them. And I know this is going to be the money shot, so Dr. Yusuf and Amani, where are you? Come on, vijana msiondoke. Just the three of us is not going to work. We need you in the picture. We'll never get the views. Ngoja mimi nisimame huku. Nimempiga video wakati anatangaza, nikaipost. Watu wanauliza mtoto wa nani huyo? Whose child is that? She's so eloquent. She knows our stuff, eh? Please, ladies and gentlemen, a hand to us. And congratulations, guys. Well done. All right, I'll be there to support you in the background next year. Okay, who has not got a shot? Who's not been in the shot? Please come through. Come over. Yes, all our other partners, eh? Karibuni, please come forward. Francis, I'm calling out names, Candida? Oh, mama yetu, karibu sana. Naomba nikupe mkono. Oh, mama unafanya gym. Karibu. Safi kabisa. Good to see you. Sprightly and healthy. Karibuni, please come through. Oh, Professor Magusi. Uh-oh. I have some space upande huu. I've got some space. Au nikuingize hapa. Yeah, angle in towards the edge of the seats, yes. AAPH staff, are you here already? AAPH staff, please songa mbele. Take steps forward towards the picture. Karibuni mbele tafadhali. Let me see some movement. Here we go. Thank you everyone for coming through. A final shot today is to the hardworking, very dedicated staff of AAPH. I'm sure you've had a fantastic welcome from them. They've taken good care of you, very well prepared. For those who joined us online, if you're still with us, or if you've signed out, I hope this was as exciting as touted, as well as very productive today. But it's all been made very possible in country, welcoming so many guests from all across the world by these very dedicated, mostly young men and women of AAPH. Congratulations, guys. You deserve this. You deserve our hands once again. And reward us with your smiles, please. And Amani, here's the mic. Please sign us out from the main stage.
Thank you, Taji. The guests of honor and everyone, the organizing team, our friends from Harvard, our friends from Germany and other European countries. We are humbled to have you here in Tanzania, and everyone who was in Tanzania to have you here at Serena to attend this important meeting. And we truly appreciate your continued collaboration and support. And hopefully, when we make another call, you'll be here to support us once again. So as we break out, please feel free to collect a coupon and go get some lunch, continue the conversation, and let's see that impact while engaging the adolescents and making a difference. Karibuni sana.
Ladies and gentlemen, it's a wrap. Let's go get nutriated. Hatuna mziki kidogo. Kumalizia shughuli kimya kimya. AAPH team, please remain behind. AAPH team, please remain behind. Congratulations once again. But if some of us could lead our guests towards the lunch area, that would be great.
We also believe